نتمنى لكم. بابا المايكات سدوها، احنا خو ما نقضي المحاضرة كلها سدوا المايكات سدوا المايكات. الموضوع كل سهل، المايكات سدوها يا اخوان. Okay, today we are talking about very important topic related to anesthesia and all the branches of medicine. It is of everyday practice. The use of fluid is essential part of the management of most patients, especially in anesthesia and ICU. And we're gonna talk about the physiology, about the fluid and distribution of fluid within our bodies, and also the management specifically related to anesthesia as post-operative anesthesia and patient presented to the casualty with hypovolemia or with dehydration, and how manage these cases. And there will be throughout this presentation. اخواني اعزائي، هاي الاصوات سدوا المايكات يا اخوان، المايكات سدوها يا اخوان. And there will be answers of the following questions throughout this presentation. What are the factors that govern the movement of fluid in different fluids compartments? What are the advantages and disadvantages of crystalloid and colloids? What are the advantages and disadvantages of normal saline and ringer lactate? What are the benefits of preparing glucose saline? Glucose saline is a type of crystalloid and prepared in different formulae, 1/5, 1/3, 1/2. What's the role of hypertonic saline 3% in fluid management? How does the body response to trauma affect postoperative fluid management? What are the differences in the management of hypovolemic shock and dehydration? What's the effect of colloid on patient with renal failure? All these questions gonna be answered throughout this presentation, and if any of these questions haven't been answered, please alarm me. As a part of improving our behavior and progress, to keep up our progress, we have to surround ourselves with people who talk about visions and ideas rather than talking about peoples. So please stop talking about peoples. These people, maybe this person without knowledge, this person without ethics, this person without skills, this person without communication skills. Stop that and focus on yourself and talk about the visions and ideas, your goals in the future, and your idea to improve yourself. And at the same time, please stop hearing to those who are talking about peoples, talking about other peoples. This is of no benefit. On the opposite side, this will stop your progress, because this gonna give you a feeling that you are better than them, and this is actually the starting of end rather than the start of progress. Some of you may underestimate this essential rule of behavior, but I think it is the essential rule to progress ourselves, to stop talking about people first, and second, to stop hearing who are talking about other persons. We have to talk about visions and ideas. The visions, our looking towards the progress, our looking to achieve our goals, and ideas are the facts can improve ourselves, and we are unrelated, irrelevant to the people if those people were without science, without skills. We are focusing on ourselves rather than others. Return back to the main topic, the fluid and total body fluid and its distribution in our body. The intracellular compartment consists of about two-thirds of total body fluid, while the extracellular compartment composed of about one-third of total body fluid. Furthermore, the extracellular compartment is subdivided by endothelium of the capillary wall into intravascular and interstitial compartments. The intravascular compartment composed of about one-fourth to one-third, and the interstitial compartment consists of about two-thirds to three-quarters of the extracellular compartment. So, in another scheme, the total body water consists of about 70% of total body weight. And this 70% divided into intracellular fluid, 40% of total body weight, and 20% to the extracellular fluid. This 20% further subdivided into 15% of total body weight for interstitial fluid and 5% for the plasma volume. This distribution of the body fluid, water in the muscle and solid organs more than the water in the fat and bones. So the young and lean adult have a greater percent of total body weight than elderly and obese. Why? Because obese contain more fat than those young adult healthy. Average young adult male consists of about 60% water of total body water, while the average young adult female about 50% of water from that of total body water because of high adipose tissue in the female, more than that of male. So this may give a difference in the percent of total body water and about 10% between male and female. Newborn infant consists of about 80% from the total body water, and this percent decrease to 60% by 1 year, and then to be constant till reaching the 60%. The composition of extracellular and intracellular fluid in related to electrolyte, as you see here, the sodium mainly in the extracellular compartment more than the intracellular fluid, while the potassium mainly in the intracellular compartment. The chloride follow the sodium mainly in the extracellular compartment, and the bicarb mainly in the extracellular compartment, while the phosphate mainly in the intracellular compartment. And regarding the physiological consideration in pediatric, we can classify pediatric age groups into those who are just 28 weeks of gestation. We found that the total body weight about 80%, while those who are delivered in care consist of 70 to 75, extracellular fluid about 30 to 40% of total body water, so more than the young adult. And then after that, with more growth, gradual shift from extracellular to intracellular compartment. At the age of 3 months, which equivalent to 6 kg body weight, reaching 70%, with further in the intracellular, extracellular compartment, the intracellular fluid more than that in the extracellular fluid. With 1 year old, 60%, the extracellular compartment decreases from this percent till reaching about 27% as the normal percent, as we have mentioned, about third of the total body water. And here, regarding the cardiac reserve, the amount of blood, that is to say, the intravascular compartment in relation to extracellular compartment. The children have a higher cardiac output to blood volume ratio than adults. If we look at these numbers, we can find that the premature infant contain about 90 to 100 ml per kg, while the term infant with the 3-month age from 80 to 90 ml per kg. Children over the older than 3 months, about 70 ml per kg. Very obese children, 65 ml per kg. And you can get a benefit of these numbers during anesthesia of pediatric age group or in the pediatric ICU when the patient complaining of bleeding. You can calculate according to the number of mils per kg, and suppose that the patient of 10 kilogram and he is children older than 3 months, so 70 ml per kg means the total blood 70 multiplied by 10 kilos will be 700 ml. The total blood volume 700 ml. So you can calculate the loss, and accordingly you can calculate the percentage of the lost blood, and accordingly the type of management, whether to be by just fluid or by giving a blood transfusion. Calculating a water deficit or surplus, the water loss equal to desired total blood water minus the current total blood water. How can we get the current total blood water? Current total blood water equal to 0.6 multiplied by current body water weight. Ahmed Muhammad. Ahmed Muhammad. Ahmed Nouri. Ali Muhammad Dnan.
نعم أستاذ.
Okay, Ali. Ali, what do you
نعم.
think? What do you think the cause of calculating by multiplying by 0.6?
دكتور احنا قلنا بالبداية 60%.
Okay. So this is the represent the 60% of the total body water multiplied by
Yes.
the. Okay, thank you. What about the desired total body water equal to measure serum sodium? Measure means the actual current reading of the sodium multiplied by the current total body water, which is can be get from this equation, over the normal serum calcium sodium, which is known for all of you. From this equation, we can get the desired total body water. Desired total body water. The fluid intake is derived from two sources, either exogenous or endogenous. The exogenous is either through drinking or ingestion of the food that contain within it a fluid, while the endogenous by metabolism of food itself, and according to this food, 1 gram of fat can produce 1 ml of fluid, while the 1 gram of carbohydrate can produce 0.6 ml of fluid. 1 gram of protein can produce 0.4 ml of fluid. So this is the endogenous fluid after the metabolism. One of the end products is the fluid, and here from the direct from the fluid through drinking or with eating, the eat contain fluid itself. What about the fluid loss? Fluid loss, either insensible loss or measured losses. The insensible loss through the skin by sweating and lung moisture from humidified air. It is totally about 800, while the measured losses through renal and gut, through renal about from 500 to 1200, and within the feces about 500. The total loss about from 18 to 2500. The fluid balance equal to fluid input over fluid output and should be equal to 1 to be balanced. So the fluid input should be equal to the output. If the ratio more than 1 means positive fluid balance, that is to say input more than the output. If the ratio less than 1, negative fluid balance, the input less than that of output. Now, we are talking about very important terms, osmolarity and osmolality. The osmolarity determined by the amount of solute dissolved in a solvent. The solvent, like for example, water, measured in a volume of liters. So it is a number of osmoles per liter of solution and plasma osmolarity, while the osmolality is a number of osmoles per kilogram of the solution and plasma osmolarity. So these are two different terms but reflect one meaning, which is the number of osmoles per either a liter or a kilogram. A liter means in the volume and kilogram in a mass. So when we are talking about osmolality, reflecting that per a unit of mass. Osmolarity, reflecting that per unit of volume. It is equal to about 280 to 300, and calculated osmolarity can be obtained through this equation. The osmolarity equal to sodium multiplied by 2 plus the glucose and body nitrogen urea multiplied by a factor to convert the unit from milligram to millimole. That is to say, these numbers, this one and this one, just to convert the unit of glucose from milligram to a millimole, and here also from milligram to a millimole. While these two reflect the presence of two ions at the same time with sodium, which is the sodium and chloride. So multiply by 2. And sometimes added the potassium here. This equation is different from this by adding the potassium. And sometimes, like in this equation, ignore the potassium. Anat Saad. Anat Saad. Ayat Shallal.
نعم دكتور.
Okay, Ayat.
اتفضل أسمع.
Ayat, what do you think that in this first equation there is no potassium? There is ignorance of the potassium. What do you think the cause?
ما عندي علم دكتور.
Okay, thank you. Why? Because potassium mostly intracellular rather than the extracellular, and the osmolarity calculated for the extracellular, the blood osmolarity. And so the very little number of the potassium sometimes to be ignored in comparison with very high number of sodium and chloride and other glucose and body nitrogenuria. There is osmolar gap. What does it mean, osmolar gap? Osmolar gap, the measured osmolarity minus the calculated osmolarity. This is the calculated osmolarity. After the calculation and getting the result, there may be a difference from the measured osmolarity, measured by a device, calculated by equation. Because of this difference between measured osmolarity and calculated osmolarity is the presence of an unmeasured compound, unmeasured, or let's say uncalculated compound, uncalculated within this equation means compound other than sodium, glucose, body nitrogenuria, and chloride. Like what? Such as alcohol, mannitol, glycerol, or others. All these not calculated in the previous equation, but during the measurement by a device involved within the measurement, and so there will be higher measured osmolarity than the calculated osmolarity. Now we are reaching very essential part of this topic, and the understanding of the movement between intracellular and extracellular compartment is the essential part of the understanding the management of the fluid, how the fluid moves between intra and extracellular compartment. The only factor that govern the movement of fluid between intra and extracellular compartment is the osmolarity that we talked about in the previous slide, the osmolarity. This is the only factor that control the movement between intracellular and extracellular compartment. So the osmolarity, which is normally from 280 to 380, the increase of osmolarity, the decrease of osmolarity lead to movement of fluid between intracellular compartment and extracellular compartment. Here the tonicity means the osmolarity with a little differences we will talk about later, but here the increased tonicity means increase in the osmolarity lead to the fluid shift from intracellular compartment to extracellular compartment. And this leads to the shrinkage of cell. Why? Because the fluid leave the cell towards the extracellular compartment, so there will be cell dehydration or cell shrinkage. The decrease in the osmolarity lead to fluid shift from extracellular compartment to intracellular compartment, causing the swelling of cell. So this movement is the opposite of this movement. The first one lead to shrinkage of cell, and the second one to the swelling of cell. The cell membrane permits water to move through it freely in or out of the cell. According to what? According to the osmolarity. So the major factor influencing this movement is the osmotic gradient across the membrane, that is to say cell membrane. The main contributors to osmotic pressure are the electrolytes, as we have mentioned. Large molecules such as proteins and charged particles such as electrolyte do not readily cross the cell membrane, but glucose does readily do so by facilitated diffusion. Return back to this slide, that the end result of the movement of fluid, either shrinkage of cell or swelling of cell. To realize the importance of this end result, let's say we are talking about intracellular compartment, means the cell, and we are talking about all cells. Some of these cells within the vital organs like brain, myocardium, liver, kidneys. So the shrinkage of cerebral cells is so essential. The swelling of cerebral cell also essential. This is shrinkage or swelling can produce hazardous effect, like that starting by dizziness and ended by convulsion, coma, and sometimes ended with cardiac standstill by stopping of breathing or affecting the cardiac center or vasomotor center. So it is not a joke. We are not talking about shrinkage of skin cell. We are not talking about swelling of fat cell. These are peripheral tissues, but we are talking about the vital organs, and small changes within these vital organs may produce hazardous effect, like that we have just mentioned, related to cells within the brain or cells within the myocardium. So you can imagine the importance of understanding this movement between intracellular and extracellular compartment, and understanding the danger of this movement between intracellular and extracellular compartment. What about the movement? We have two types of movement. First one, we have just mentioned between intra and extracellular compartment. Second one, between the plasma and interstitial fluid within the extracellular compartment. The first one, controlled by the osmolarity. The second one, which is we are talking about now, controlled by other mechanism. What's this mechanism? Let's say gaps between endothelial cell allow free movement of electrolytes and other small particles between plasma and the interstitial space. So the wall that separate intravascular from interstitial compartment is the endothelial cell of the vessels, and this is a semi-permeable wall, permit for all the free fluid and all the electrolytes and other small particles to move freely. And this is different from the cell wall that separate intracellular from extracellular compartment that we talked about already. We mentioned that the cell membrane permit only for fluid to move freely. It does not allow for even electrolyte to move freely. While here, the endothelial cell or the endothelial membrane allow for the movement of not only fluid but also the electrolyte and all these small particles. Only the large particle cannot move between the interstitial and intravascular compartment through the semi-permeable membrane between these two compartments. So the protein cannot pass, and the resulting of this not passing of a protein and pressure difference between the two compartments, we call it osmotic pressure or oncotic pressure, which is here regarded as added factor to control the movement between intravascular and interstitial compartment. Movement of fluid between these two compartments depend on three factors. First, hydrostatic pressure of intravascular compartment. Second, hydrostatic pressure of interstitial compartment. And third, the oncotic pressure of the intravascular compartment. And according to these three factors, we can get this equation: hydrostatic pressure in the vessels minus the summation of hydrostatic pressure in the interstitial fluid plus the oncotic pressure within the vessels. In the arteriole, the hydrostatic pressure more than that in the venule. So the end result will be the shift from the intravascular to the interstitial here. This is normal physiological condition, while in the venule shift from the interstitial to the vein. ضحى قدوري. أحمد عواد.
نعم أستاذ.
Ahmed,
نعم أستاذ.
what do you think the cause of ignorance of the osmotic pressure in the interstitial compartment? We have here three factors: hydrostatic pressure intravascular, hydrostatic pressure interstitial, oncotic pressure intravascular. Why we ignore the oncotic pressure in interstitial?
ما أعرف أستاذ صراحة. ما أعرف.
Thank you. Because the oncotic pressure the oncotic pressure in the interstitial that reflect the large particle nearly null, nearly zero, so it is ignored. Ahmed Salim.
نعم أستاذ.
Ahmed Salim, now according to my explanation, what's the factor that control the movement between intracellular compartment and extracellular compartment?
نعم أستاذ بالنسبة للهيدروستاتيك بريشر هو يعني البوشنج.
أحمد
نعم
بس
أستاذ.
اسمعني بابا اسمعني.
أي أستاذ.
factor that control the movement between intracellular and extracellular compartment.
العفو أستاذ، فقط الأوزموتيك احنا قلنا هو المين فاكتور.
الأوزمولاريتي.
Osmolarity.
Good. Thank you, Ahmed.
نعم.
Thank you, Ahmed. سبأ محسن.
نعم أستاذ.
سبأ. What are the factors?
صبا.
What are the
نعم.
factors? What are the factors that control movement between intravascular compartment and interstitial compartment?
hydrostatic pressure وoncotic pressure.
Okay, thank you. Now we're gonna talk about the control of body fluid and electrolyte. We have mentioned that the movement of fluid from intracellular or to intracellular causing either shrinkage or swelling of these cells, and this may produce hazardous effect. So it is not easy to produce such a hazardous effect. Why? Because our body under strict control by several factors that prevent such abnormal or dangerous sequelae. For example, any increase in the osmolarity means the increase in the osmolarity which causing the movement of fluid from intracellular to extracellular compartment. This is the body defense mechanism causing first thirst, the feeling of thirst that return back the osmolarity towards normal after drinking of water, and second, increase the secretion of antidiuretic hormone to prevent the secretion of fluid and keep it in our body to counteract the increase in the osmolarity, and so to return the osmolarity towards its normal value. So now the regulation of fluid intake, if we have drink 2 liters of water, this 2 liters of water causing what? Decrease in the osmolarity. The decrease in the osmolarity will lead to movement of fluid from the extracellular compartment to intracellular compartment. And to prevent that, there would be a defense mechanism of decreased antidiuretic hormone. So increase the water what? Secretion. That is to say, decrease the water reabsorption. And at the same time, this 2 liters of water causing increase the plasma volume, so increase the blood pressure, decrease in the sympathetic, and as a defense mechanism, there will be decrease in aldosterone secretion. This leads to decrease in sodium reabsorption, ending with the decrease water reabsorption, that is to say, increase in the water excretion. So we have very strict defense mechanism in our body to prevent such abnormal sequelae unless there is a pathological condition. A pathological condition that affect some of these factors that involved within the defense mechanism, or there is another factor like fasting of water, inability to drink water, or there is intestinal obstruction, or there is any problem or pathological condition that interfere with either drinking of water or with excretion of the water. How do I know someone needs a fluid? Yeah. How can we assess the volumic status of any person? First, by physical examination, depending on several factors: heart rate, blood pressure, mucous membrane, urine output, orthostatic blood pressure means the difference between supine and standing blood pressure, breathing, consciousness level. All these parameters are important during physical examination to assess the volumic state of the patient, and also furthermore blood evaluation by the blood investigations, hematocrit, pH, urine specific gravity, sodium within urine, within serum, chloride, body nitrogen, urea, creatinine, all these to be assessed well, reaching the final assessment of the volumic state of the patient. And furthermore, clinically, we can get a benefit of CV line, arterial line, Swan gas analysis, all these involved within the assessment. Water depletion means decrease the amount of water in our bodies, and clinical feature of this condition, the main symptoms are weakness and intense thirst. Why this intense thirst? We already said this is a part of our defense mechanism. Second, the urinary output is diminished and its specific gravity increased because the urine become concentrated. The increased serum osmolarity causes water to leave the cells intracellular, causing intracellular dehydration, and thus delay the onset of overcompensated hypovolemia. This is very important point to be imagined. Please think with this movement. Here, there is an increase in the osmolarity, with hypovolemia. The body, as a part of this defense mechanism, causes water to leave the cells, and this leaving of cells causing intracellular dehydration, and thus delay the onset of overcompensated hypovolemia. That is to say, here, if you measure blood pressure, pulse rate, all these will be normal. Why? Because the body compensates the loss of water in the extracellular compartment, in the intravascular compartment, by the movement of water from the intracellular compartment to the extracellular compartment, leaving the cells with intracellular dehydration. But this is accepted. Why? Because the important part to be controlled to be in good volumic state is the intravascular compartment. Why? Because through the intravascular compartment, we can maintain the blood flow to the whole body tissue and specifically and most important to the vital organs like the brain, the myocardium, the lung, liver, and kidneys. So this is essential and important defense mechanism to overcome the hypovolemia by movement of fluid from the intracellular compartment to the extracellular compartment. Another condition, water intoxication. The causes are excessive amount of water with low sodium or hypotonic solution. Another cause, colorectal washout through some GIT surgery with plain water rather than with the normal saline. A major component, that is to say intoxication of the TURP, transurethral resection of prostate. Through this surgery, there will be continuous washout. If we use hypotonic fluid through this washout, there will be continuous absorption of this hypotonic fluid, leading to decrease in the osmolarity of the body, and this leads to the shifting of fluid from the extracellular compartment to the intracellular compartment, causes intoxication, water intoxication. The fourth cause is the syndrome of inappropriate antidiuretic hormones secretion, called SIADE syndrome. In this syndrome, in which antidiuretic hormone is present and acting, but the primary stimulus for its release اللي هو شنو hypernatremia and low effective circulating volume are absent. So there is exaggerated effect of the antidiuretic hormone without the presence of the usual primary stimulus factor. The source of antidiuretic hormone normally is the posterior pituitary or from the non-physiologic source such as the neoplasm. An increase in the antidiuretic hormone leads to limits the secretion of extracellular fluid water, which causes hyponatremia and initial extracellular fluid expansion. In response to this expansion, sodium is excreted and extracellular fluid returns to normal, but patient is still hyponatremic. Now, reaching another part of this presentation, which is the types of fluid. We have two types of fluid. السلام عليكم، تسمعوني؟
اي استاذ نسمعك،
نسمعك
هسه رجع الصوت
اي
معنا.
نعم استاذ.
Now we're reaching the two types of fluid, colloid versus crystalloid fluids. The crystalloid fluid composed of water and electrolytes or simple crystals, like for example glucose. The volume of distribution of a crystalloid between intravascular and interstitial space. And as you know, the volume 3 to 1, 3 in the interstitial space and 1 in the intravascular compartment. The examples of this type of crystalloid: ringal lactate, hypertonic saline, and normal saline. These are examples of the crystalloid type of fluid. The contents of the IV fluid, if we are talking about dextrose water, 5% glucose water, consists of 5% of glucose in water. This 5% means 50 grams per liter. And this 50 grams per liter can produce 200 calories per liter. The pH of this type of fluid is 4.5 and the osmolarity 252. What about normal saline, which is 0.9% saline? When we say normal saline, means 0.9% sodium chloride within the fluid. The sodium concentration 154 milliequivalent per liter. The chloride also 154 millimole per liter. The osmolarity 300, about 300. pH 4 to 5 means acidic solution. And this type of fluid does not supply free water. What does it mean? This type of fluid does not supply for free water. Muna Karim. إسراء.
نعم أستاذ.
What does it mean that this type of fluid, normal saline, does not supply free water?
يعني ممكن يكون إنه يعني ما يوفر لي فري ووتر إذا احتاجته يعني بعض يعني البيشنتس.
Okay, thank you. Does not supply free water means that this type of fluid with the same osmolarity of our body, so there is no free water to be shifted. Once infused in the intravascular compartment, this will stay within the extracellular compartment as it is, without any free water to be shifted to the intracellular compartment. So we can get a benefit of all this volume of fluid. So it is very important in the management of patient with hypovolemic shock. The side effect of this fluid sometimes may cause hypernatremia and hyperchloremia. Why? Because the content of this fluid is sodium chloride. Here the ringal lactate solution. The ringal lactate contains sodium 130 milliequivalent per liter, chloride 109, And in addition to the normal saline, here we add potassium, calcium, and lactate. The osmolarity about 273. The pH here is higher than other types of fluid and reaching near the normal body or pH, about 7. So it is more physiologic than other types of fluid. But this type of fluid, which is the ringal lactate, supplies 100 ml of free water, 100 ml of free water. Hadil,
نعم أستاذ.
why this type of fluid supply 100 ml of free water?
لأن الأوزمولاريتي مالته عالية.
اوكي شكرا. هنا راح نشوف شنو فرق هذا عن النورمال سلاين. بالنورمال سلاين قلنا النورمال سلاين contain only sodium chloride، والصوديوم كلورايد هو اصلا extra cellular compartment، فراح يبقى iso-osmolar and there will be no change in the osmolarity. Here in the ringal lactate, there is adding of other electrolyte, potassium, calcium, lactate, with on the account of decreasing in the sodium chloride. And these electrolytes will be left to the intracellular compartment or metabolized to other electrolytes. And so this will decrease the osmolarity of this fluid after infusion in the intravascular compartment and causing the decrease in the osmolarity. So there will be about 100 ml free water per each liter. It is very small percent, but we have to consider it and to know the cause beyond this free water. Here, the 1/2 normal saline. This is, I think, unavailable, but from the theoretical point of view, that it is easy to understand that this is 1/2 the normal saline, means the osmolarity of this type of water is the half that of the normal saline. So this can supply about 450 ml of free fluid per liter. Here the 5% glucose water plus 1/2 normal saline, because this is a mixture type of the crystalloid fluid, consists of the same percent of the dextrose glucose as that of the 5% glucose saline, glucose water, with the adding of the 77 millimole of sodium and chloride. So here the osmolarity will be just as 1.5. So the osmolarity here more than the that of the normal saline alone, or ringal lactate alone, or glucose water alone. But the pH here decreased because of the both glucose and sodium chloride, both of them decrease the pH and increase the acidity. This is same the previous one, but with the addition of the 1/5 normal saline rather than 1/2. normal saline to 5% dextrose water. Here the 10% dextrose water, I think you have seen this fluid in our hospitals. It contains more glucose than that of 5% glucose water, and so produce more energy and produce more glucose and with higher osmolarity. This is a combination that I haven't seen, consists of both 5% dextrose water plus the ringal lactate, so there will be higher osmolarity. And this type of fluid available in our hospital اللي هو consists of 5% dextrose water plus normal saline with the double osmolarity, just like giving both content of normal saline and dextrose water within the 500 ml in the bottle and within the 1 liter in 2 bottles. Here, maybe you haven't seen this type of fluid, which is 3% sodium chloride, so we call it hypertonic saline. Hypertonic saline that contain the sodium in about 513 millimole or milliequivalent per liter, and the same amount of chloride, and this lead to very high osmolarity, about 1026 per liter. Only used for this type of fluid for hyponatremia complicated by seizure or hemodynamic instability. Hamdiya. Hisham Ahmed.
نعم أستاذ.
Okay, Hisham. Hisham,
نعم أستاذ.
can you see this osmolarity?
نعم.
What do you think the infusion of this type of fluid to our body, what can cause?
احنا أستاذ على مود التونسيتي، يعني كل ما راح ننطي أكثر الهايبرتونيك سيرين على مود التونسيتي أو الأوزمولاريتي، يعني اللي سببتها. يعني أنا عندي هايبوناتريميا، فمن أنطي يعني هذا الهايبرتونيك سيرين فأكيد راح تزيد الأوزمولاريتي لأن التونسيتي يعني أكبر.
نعم، فإذا زادت الأوزمولاريتي إيش راح يصير؟
يعني التونسيتي تزيد، أنا عندي هايبوناتريميا، الأوزمولاريتي عندي قليلة.
نعم. Okay, thank you, Hisham. The infusion of this type of fluid lead to increase in the osmolarity, actually exaggerated and excessive increase, not mild increase, because the osmolarity of our body about 300, and this is more than triples times increase in the osmolarity, and this causing excessive movement of fluid from the intracellular compartment to the extracellular compartment, and this can produce sophisticated complications. So this type of fluid restricted to very, very limited indications. Actually, it is not available in our hospitals. Now, the choice of the IV fluid types, we have mentioned several types of crystalloid fluid. How can we choose which type suitable for the patient? General factors on which to base the selection depend on the sodium content in our body or in the patient, osmolarity, pH, amount of free water supply, need for glucose, calories, anticipated rate of administration. All these factors play a role in the choosing the suitable type of fluid to be infused for the patient. Lactated ringer, the fluid of choice for any situation where large and rapid bolus treatment needed. If patient presented to the casualty with hypovolemia, severe hypovolemic shock, and need rapid infusion, rapid replacement, in this situation, ringer lactate is the fluid of choice. And in prolonged high rate needed, like in patient with burn, in mild to moderate acidosis from volume depletion, in eye irrigation, because this is a buffer fluid with a pH nearly equal to that of our body, about 7. This can give more than 40 liters of ringer lactate during 24 hours, and the serum electrolytes will stay normal without any danger. The contraindication of ringer lactate in patient with renal failure because of the presence of potassium. And you know, one of the rule of giving potassium is the normal urine output. Need maintenance glucose. In this situation, we have to give the fluid contain glucose. Need more than 100 ml per liter of free fluid. Note that lactic acidosis not a contraindication because the lactate will metabolize into bicarb, and in cases of blood transfusion because causing clotting in the same line, yani giving state. The normal saline is the fluid of choice for volume depletion in a patient with renal failure, because in renal failure we cannot give a ringer lactate, or uncertain renal status, such as patient with the DKA, diabetic ketoacidosis, in condition with moderate hyponatremia due to volume depletion, in patient in which diluent went for blood transfusion in the same line. The contraindication for normal saline if a prolonged or large volume rapid infusion causes hyperchloremic acidosis and hypokalemia. In cases of needing a buffer solution, pH of normal saline is 4. So here it is contraindicated, and the alternative is ringer lactate. Need a maintenance of potassium. Normal saline has no potassium. Sensitivity to sodium in patient with congestive heart failure, for example, or with high blood pressure. Need maintenance of glucose, and this type of fluid has no glucose. Here we have several types and formula of the normal saline, which is 1/2 normal saline or 1/5 normal saline. 0.2 means 1/5. Useful when the patient sensitive to salt load or requires more free fluid rather than that of the patient require normal sodium. Give an example. The example in case of, for example, heart failure, and at the same time with hypovolemia, or in pediatric age group. This is essential and important to be used in the pediatric age group. D5 solution, which is 5% glucose, the contraindication. تشوفون هاي التوقفات مالتي، هاي التوقفات اسمع صوت فلازم اطلع من المحاضرة اروح على الاسماء اسوي ميوت لهذا الصوت وارجع مرة ثانية. Contraindication of 5% dextrose whenever rapid fluid bolus required, if given as a bolus, can raise blood sugar to more than 900 and cause hyperosmolar coma even in non-diabetic patient. So this is a case of an increase in glucose level due to rapid infusion of 5% glucose solution, which is here contraindicated because it is of no benefit more than giving a glucose in a patient without glucose deficiency or decreased glucose level. So rapid dextrose water bolus causes hyponatremia and hypokalemia, hyperglycemia, secondary cerebral edema. Some pediatric deaths reported from receiving rapid 5% dextrose water boluses. Hyperglycemia, well understood because we are infusing glucose solution. Why hyponatremia and hypokalemia? Because we are infusing a fluid with no sodium, no potassium, and the amount of sodium and potassium in the intravascular compartment is fixed. With the increasing of volume lead to decrease in the concentration. Why secondary cerebral edema? Because the infusing of this fluid causing decrease in the body osmolarity, and this decrease in the osmolarity lead to movement of fluid from the extracellular compartment to the intracellular compartment. And the cerebral cells are part of the intracellular compartment. So there will be cerebral cell edema. And this is not a joke, can produce hazardous effect. This table contains the main constituent of different types of crystalloid solutions. And here also different types of fluid with the osmolarity, glucose, sodium, and chloride constituents. And this is the distribution of fluid in the different compartments after the infusion. So if we are talking about, for example, this is normal saline. The infusion of normal saline causing the distribution within the extracellular compartment consists of interstitial and plasma, mainly in the interstitial, about from 2/3 to 3/4, and lesser in the plasma in the intravascular volume. This is the intravascular volume from 1/4 to 1/3, with the same percent of the extracellular compartment that subdivided into 1/3 intravascular and 2/3 interstitial. Here, balanced crystalloid, for example, ringal lactate, with the same of normal saline with mild differences. Here, the glucose, 5% glucose, mainly will be moved to the intracellular compartment, and with 1/3 to the extracellular compartment, and this 1/3 further distributed in the interstitial, and very small amount in the plasma. So after infusion of 1 liter of glucose, 5% glucose, there will be only 72 ml out of 1 liter. Imagine that, out of 1 liter, only 72 will be remain in the intravascular compartment. And other types of the fluid, if you understand the mechanism of movement of fluid and the compartments, you can imagine and understand the movement of all types of fluid without difficulty. You can imagine and realize the distribution of fluid, different types of fluid within different compartments of our body, if you understand the mechanism of movement between different compartments, and if you understand the compositions of these compartments. Now we are reaching the second type of fluid, which is the colloid we will talk about. If you look at this type of fluid colloid, 1 liter of fluid infusion will stay in the intravascular volume only. 1 liter giving, 1 liter in the intravascular fluid. No movement of fluid to interstitial compartment. No movement to the intracellular compartment. This is already explained in this slide, the same. And here the fluid distribution following infusion of 1 ml of a crystalloid. These are different types of a crystalloid. And here the composition and how the distribution between extracellular and intracellular compartment here. Same like that explained in this slide. Before starting talking about colloid, here the rate of metabolism of glucose. The glucose is, يعني after giving, for example, a patient with 5% glucose, what's the rate of metabolism of this glucose? Glucose is metabolized at a rate of only 0.2 gram per kg body weight per hour in an ill or stressed patient. So about 14 gram of glucose metabolized in a 70 kilogram body weight patient, while the 5% dextrose contain 50 gram of glucose. So this number 14 is almost about 30% of 50, of this 50. Thus, the glucose water should not be infused more than 300 ml per hour and less if the patient is already hyperglycemia. Why? Because the infusion of more than this volume lead to hyperglycemia even if in a non-diabetic patient. طبعا unless there is a reasonable indication for infusion more than 300 ml. What about the colloid? Colloid is a fluid with higher molecular weight substances. Almost always are iso-osmolar with the same osmolarity of the body. Their high oncotic pressure is due to large molecules that normally don't cross the capillary membrane. Volume of distribution within the intravascular compartment, the volume 1:1, as I have just mentioned, 1:1. If you infuse 1 liter of colloid, this 1 liter will stay in the intravascular compartment. This exerts colloid osmotic pressure. These types of the colloid are costly, more cost expenses than that of the crystalloid. Examples: الهيماسيل, albumins, dextran, hydroxyethyl starch. The colloids contain proteins or other large molecules that do not pass from the plasma to the interstitium to keep the infused fluid largely in the circulation in the intravascular compartment. Restoring the circulating volume with this fluid is rapid and sustained. So it is of importance in the management of patients with hypovolemic shock. Why? Because all the infused fluid will replace only intravascular compartment. So there will be a rapid increase and replacement of the deficit fluid and rapid return to the normal volume. Types of the colloid: we have albumin in different concentrations, 5, 20, and 25%. Half-life about 16 hours. Colloid, this albumin, for example, of the 25% can produce osmotic pressure of about 70 millimeter mercury, plasma volume by 4 to 500 ml. Volume expansion occur at the expense of interstitial fluids, so not use 25% for resuscitation. This means that the replacement of only intravascular compartment, not the interstitial compartment, not the intracellular compartment. The side effect of the albumin may be allergic reaction. Hemasil is a synthetic colloid composed of degraded gelatin, concentration 3.5%, half-life 2 to 3 hours, dose 20 ml per kg per day, produce osmotic pressure of about -300 millimeter mercury. Side effect: anaphylaxis, coagulation interference with a high dose. This means that the colloid can interfere with the further blood cross-match. So it is important to take a sample from the patient before infusion of the colloid. This sample for the further cross-match if we need blood replacement. So we have 3 side effects of colloid in general. First, allergic reaction or anaphylaxis. Second, interfere with further cross-match. Third, coagulation problem due to delusional thrombocytopenia. Delusional thrombocytopenia. Why delusional? Because we are infusing a fluid in the intravascular compartment, and this leads to increase the volume with the same number of platelets, so there will be delusional rather than actual thrombocytopenia. This is the hydroxyethyl starch, molecular weight from 200 to 450, different concentration and different hours of intravascular stay, and here the doses in ml per kg per day. Here also different types of colloid fluids with their osmolarity. If you look at the osmolarity, nearly iso-osmolar for all. The difference in the oncotic pressure rather than in the osmolarity. Here, the different types of fluid with the constituent of different electrolytes and particles. What are the major differences between crystalloid and colloid? The intravascular volume effect, colloid better than crystalloid. Interstitial volume effect, crystalloid better than colloid. Pulmonary edema, both of them in the same potential effect. Peripheral edema, common with the crystalloid and uncommon with colloid. Reaction absent in crystalloid and common in colloid, and the colloid is expensive while the crystalloid is inexpensive. Resuscitation crystalloid solution dilutes plasma proteins, lead to reduction of plasma oncotic pressure and interstitial pulmonary edema. While the isotonic crystalloid must be infused at least threefold greater volume to achieve comparable plasma expansion and hemodynamic stability. Ashraf.
نعم أستاذ.
Ashraf, why the infusion of isotonic crystalloid must be at least threefold greater volume to achieve comparable plasma expansion and hemodynamic stability?
أستاذ على مود الأوزمولاريتي، يعني تكون هاي أوزمولاريتي على مود نسمح إنه الفلويد ينتقل من الاكستراسيلولار للانتراسيلولار.
اوكي شكرا أشرف. هيام محسن.
نعم أستاذ.
هيام هنا according to this statement, if somebody lost 500 ml of fluid, we have to replace by 3 times, that is to say 1.5 liter. Why? To achieve comparable plasma expansion.
ما أعرف أستاذ.
شكرا. This is why, because if somebody lost, for example, 500 ml of blood, and we want to replace by isotonic crystalloid, let's say ringal lactate or normal saline, we have to infuse 1.5 liters of ringal lactate or normal saline to replace half liter of blood, because the infusion of the crystalloid lead to distribution of this crystalloid within extracellular compartment in both intravascular and interstitial compartment. So if we classify the extracellular compartment into 1/3 intravascular and 2/3 interstitial, there will be staying of only half a liter within the intravascular compartment out of 1.5 liter, and 1 liter in the interstitial compartment. So we have to infuse 3-fold greater than the lost volume from the intravascular compartment to be replaced. Here the colloid, if we infuse a colloid, will remain in the intravascular compartment, while if you infuse a crystalloid, there will be shifting and distribution between both intravascular and interstitial. 2/3 of this crystalloid will remain in the interstitial compartment, and 1/3 will remain in the intravascular compartment. colloids fluid بشكل عام, additional cost and potential risk of colloids. Removal of colloids requires longer period than crystalloid in burn and major surgical patients. In patients with sepsis, ARDS, surgical trauma, in those patients, there may be capillary permeability, lead to leak and edema. Coagulopathy, in patients with coagulopathy, if we give dextran or starch more than 20 ml per kg, causing coagulopathy by dilutional thrombocytopenia, and this causing decrease in the ionized calcium albumin, impaired in the cross match of blood, further cross match as I already mentioned. So this require taking a sample before infusion of dextran, and also can cause osmotic diuresis if we use low molecular weight dextran, work as osmotic diuresis. Now, what to give? The decision of using crystalloid or colloid. The crystalloid first preference when available, like normal saline, ringal lactate. Colloid, keeping in view of adverse effects, we have to consider their adverse effect, and using a reasonable dose. Colloid can be given with a crystalloid in patient not responded to crystalloid only during the resuscitation of patient with hypovolemia. Avoid albumin in the resuscitation of fluid. Use synthetic colloid rather than the albumin. The dehydrated patient who receive considerable amount of hyperoncotic colloid is especially at risk for developing acute renal failure, because the patient already dehydrated with decrease in the renal blood flow, and here we will add more load on the kidney by large particles. It may be advisable to administer colloid in addition to rather than without crystalloid, because the crystalloid can first increase the renal blood flow, and second, easily and simply to be managed by kidney rather than the colloid, which is with large particles. Hypertonic solution, which is hyperosmolar solution, already mentioned as a type of crystalloid fluid with several percents, and I mentioned that it is not available in Iraq. For example, 3% sodium chloride, 5%, 10% sodium chloride. This lead to, as it is hypertonic, lead to increase in the osmolarity. So there will be temporarily shift water from intracellular to the extracellular compartment. And at the same time, this type of fluid reduces the CSF secretion rate and production. So it decreases the production of the CSF as a side effect. Limit volume of hypertonic saline, 1 liter of 3% sodium chloride is a maximum. Too much of 3% sodium chloride may cause rebound intracranial hypertension, cause hyperchloremic acidosis and hypokalemia, causes intracellular dehydration. Hyperchloremia may cause renal vasoconstriction. So this is a very critical type of the crystalloid, and if you want to use it, we have to use it carefully with very limited volume and with the very strict important indication. Clinical studies of hypertonic saline efficacious for hypotensive brain injured patient in transfer to hospital. Lesser amount of cerebral edema may reduce intracranial pressure where mannitol has failed, improve cardiac output, promote diuresis, reduces edema, increase serum sodium to about 150 is well tolerated. Now we reach the topic related to perioperative fluid management. That is to say, the use of fluid pre, intra, and post-operative. And this is essential part of our daily work during anesthesia. The goal of fluid administration, why we give a fluid. Fluid is a part of volume, and the volume is a part of blood flow to the several organs, especially the vital organs, cerebral blood flow, myocardial blood flow, renal blood flow. So without fluid, there will be no oxygen delivery, no perfusion to these organs. For maintenance of electrolyte composition, for maintenance of glucose level, maintenance of body temperature. These are in general the goals of fluid administration. The autoconsumption at a rate of 70 kilogram adult in a rate of 3.5 ml per kg means 250 ml. So every minute the body consumes about 250 ml of oxygen, and this oxygen carried out by the blood volume, and the blood volume, if there is a hypovolemia, there will be no delivery of this oxygen to vital organs. So this is the importance of the fluid and normal fluid content within the intravascular volume. This is a part of respiratory physiology, but I added here for your review, and if you have interest to return back to these topics related to the physiology, how can we calculate the oxygen flux, delivery of oxygen delivery, and here how can we calculate the oxygen content, and here the oxygen consumption, and this is the Starling law related to the volume and diastolic volume, which is also related to the normal or abnormal volumic state of the intravascular compartment. How much of fluid and when to give it? It depends on, first, type of patient. Pediatric patient, geriatric patient, adult healthy patient, type of surgery, minor, moderate, severe, amount of trauma, patient with hypovolemic shock due to trauma or without trauma, acute injury, emergency, or elective, anesthetic types, position of the patient, who you listen to. All these are the factors that we have to consider before choosing the type of fluid and how much of fluid to be given. And we can calculate the amount of fluid according to these 4 parameters: deficit, maintenance, third space, and blood loss. The deficit, we have to estimate the pre-op, nothing peroral, fasting hours, multiplied by the duration. Pre-operative blood loss if there is a trauma, or fluid loss if there is a burn. And typically replace over first 3 hours all this deficit to be replaced over first 3 hours in amount of half the volume during the first hour, quarter the volume during the second hour, and quarter the volume within the third hour. So the deficit fluid, all the deficit fluid to be replaced within 3 hours. Why not within the first hour? Because this fluid is a deficit and we don't want to go within a fluid overload, to be replaced gradually within 3 hours. And regarding the fasting and maintenance hours can be replaced by the usual classic formula, famous formula of 4-2-1, 4 ml per kg per hour for first 10 kilos, 2 ml per kg per hour for the second 10 kilos, and 1 ml per kg per hour for each kilogram of body weight above the 20 kilogram. Regarding the third space to be replaced from 2 to 10 ml per kg per hour according to the type of surgery. For major surgery, we replace 10 ml per kg per hour. For moderate surgery, 4 to 8 ml per kg per hour. And for minor surgery, 2 to 4 ml per kg per hour. Regarding the blood loss, we depend on a 3-to-1 ratio replacement of a crystalloid that already I have mentioned, and 1-to-1 for the replacement with colloid or with the blood. Losing of half, for example, half liter of blood can be replaced by half liter of blood, or half liter of colloid, or 1.5 liter of crystalloid. Regarding the third space, the capillary and endothelial injury lead to leak, and this causing sequestration of fluid into tissue. That is to say, trauma causes fluid retention. The creation of non-functional component of interstitial fluid lead to return of fluid from this third space after 1 to 4 days after surgery. So for 1 to 4 days, there's a so for 1 to 4 days, there is a loss of this type of fluid by sequestration in other parts of interstitial compartment. So we have to replace this sequestrated fluid, and then to expect the return back of this fluid to the normal circulation within 1 to 4 days after the surgery. Which type of fluid we can use? For short fasting, 2 hours, and maintenance, we can use ringal lactate or normal saline. For long fasting, which is unscientific, you know that the scientific fasting is just 2 hours for the fluid, 4 hours for the particulated fluid, and 6 hours for the food. But if the patient with unscientific, he mentioned that he has fasted for example, overnight for about 10 to 12 hours. Here, long fasting, and here we can replace with 20 to 40% ringal lactate or normal saline, and the rest by the glucose water. Or we can use 1/5 or 1/3 glucose saline in all the total amount. For the third space and lost fluid to be replaced by ringal lactate or normal saline. Here the different types of lost fluid: sweat, gastric secretion, pancreatic fistula, biliary fistula, ileostomy fluid, diarrhea fluid, and the expected loss of electrolyte according to their normal concentrations to assess the loss and the reasonable scientific type of fluid to be used for the replacement. Risk of excess fluid: interstitial edema, impaired cellular metabolism, poor wound healing, and decreased pulmonary compliance. Heart failure lead to overload or delayed return of bowel function, and hemodilution. We reach the suggested routine post-operative fluid regime for nothing per month patient for 3 days after surgery. If the patient after surgery instructed not to take anything peroral, we have to maintain fluid for this patient by intravascular routes. And in this case, we can use a daily requirement according to 4-to-1 rule per 24 hours, or roughly speaking, we use 35 ml per kg per 24 hours. So for a 70 kilogram patient, we can give about, this is normally, I mean, normally, we can use 2.5 liter per day. What type of fluid? What type of fluid? To know the type of fluid, we have to know the normal body requirements of electrolyte. The normal daily requirement of sodium, 1 to 2 millimole per kg per 24 hours. So for a 70 kilogram body weight, the normal requirement of sodium, 70 to 140 millimole per day. And the normal requirement of potassium is half that of the sodium, 0.5 to 1 millimole per kg per 24 hours. So for a 70 kilogram patient, about 35 to 70 millimole per day. This requirement should be supplied per day by one of the following regimes. First, 1 to 2 units of normal saline or ringer lactate and the rest of glucose water plus the potassium. Or 5 units of glucose saline 1/2 or 1/3 plus the potassium. These are two regimes can be used to replace a patient for nothing by mouth for 24 hours. But we have to consider another factor. The previous slide mentioned for the normal patient requirement. But we have to consider a concept of body response to trauma, and a surgery is a type of trauma. So the patient after surgery complain of body response to trauma, and this lead to increased plasma vasopressin, cortisol, aldosterone hormones, and result in positive water balance, fluid retention, and positive potassium balance. So we have to consider this increase in the fluid and sodium in the post-operative period. So in the first day post-operatively, no need for sodium or giving less than the normal requirement. Why? Because already the patient with positive sodium balance. Also decrease the normal fluid requirement by about 20 to 30% of the normal body requirement. What about the potassium? Regarding the potassium, the cell destruction during surgery results in increased serum potassium level, so no need for giving potassium in the first 2 days. While in the third day, we can give a potassium in the same of the normal requirement of the body, which is 0.5 to 1 millimole per kg per 24 hours. So for the 70 kilogram patient, we can give 35 to 70 millimole per kg per 24 hours, giving equally with the crystalloid. That is to say, if a fluid requirement is 2.5 liter, then 10 millimole of the potassium can be given within each 0.5 liter, each bottle of the fluid, to be given over 24 hours rather than giving in the fast way that can cause dysrhythmia and may lead to complications. Rules of giving potassium, any IV potassium, we have to give it with the rules. Should be under ECG monitoring, not giving in anuric patient, not more than 20 millimole per hour, not more than 20 millimole per 0.5 liter fluid. Now, if patient present to the theater with multiple bullet injury, that is to say hypovolemic shock. In this case, the fluid in hypovolemia, we can use crystalloid solution, which can move freely in and out of the circulation, to ensure that fluid given remain in the extracellular space, it must contain an adequate sodium concentration more than 103 millimole per liter, which is available in the normal saline or Ringal lactate. The two main crystalloids suitable are Hartmann and normal saline. For treating hemorrhage, the volume of a crystalloid given should be approximately 3 times that volume lost. There is no place for fluid containing little or no sodium, like 5% glucose, 4% glucose, 0.18% sodium chloride in the management of hypovolemia. Marwa Mahsen. عبد الغفور علي شنان.
نعم أستاذ.
عبد الغفور, can you explain for me this statement? There is no place for fluid containing little or no sodium, like 5% glucose, 4% glucose, 0.18 sodium chloride in the management of hypovolemia. Why?
Because the water movement with the sodium across the cell membrane.
Okay, thank you.
Thank you.
Why this is not to be used? Because these types of fluids, in the fluid, there will be a case of a decrease in the osmolarity, and then shifting of fluid from the intravascular compartment to the intracellular compartment. And our aim in patient with shock to replace intravascular compartment, not intracellular compartment. So we want the fluid that remain in the extracellular compartment and specifically in the intravascular compartment. Colloid. The synthetic colloid solution in common use are based on the gelatin starch through still contain a sodium concentration similar to plasma. Although they produce volume expansion in the circulation for longer than crystalloid, they can produce occasional serious reaction, and their role is therefore controversial. Actually, we have mentioned that this type of fluid to be used in case of failure of the good replacement with using of a crystalloid only. So in this situation, we add colloid. So we have to consider scientific indication. They should not be used for minor hypovolemia, and their use in more major degrees of hypovolemia should be based on a balance of risk and benefit. Ringal lactate, highly hypotonic to 173 osmolarity, contain calcium, do not mix with the blood. We mentioned that. 0.9% saline, isotonic, large volume may cause hyperchloremic metabolic acidosis. We mentioned that. 5% dextrose water, hypotonic, hyperglycemia, worsening the cerebral ischemia. هيتا starch اللي هو colloid more than 20 ml per kg may cause coagulopathy due to dilutional thrombocytopenia, and the hexa starch better choice than the HETA span. Regarding the hypertonic fluid, which is unavailable in Iraq, also we talk rapid volume expansion, and this causes rapid volume expansion, increase and improvement of blood pressure and cardiac output, decreased tissue edema, intracranial pressure and brain water, improve neural function, cerebral perfusion pressure, and survival after traumatic brain injury, resuscitation fluid of choice for pre-hospital traumatic brain injury in the Europe. This is the mild, moderate, severe blood, fluid loss, not blood loss, in cases of hemorrhage, and here in other extracellular fluid means rather than the blood, like that of GIT, for example. And how can we replace according to the percent of loss? Hemorrhagic shock also can be classified from 1 to 4 according to amount of blood loss and into several percent. Some of these can be replaced if less than 15% by only crystalloid, and if the loss from 15 to 30%, we can also use crystalloid. And in this condition, we have to consider the use of colloid. And when the loss more than 30%, 30 to 40, we have to use in addition blood. And for more than 40 class 4, also we have to use blood. Limitation of replacement of fluid regarding the blood. Large transfusions can cause complications such as infection, DIC, immune reaction, biochemical disorders, already mentioned in the complications of a blood transfusion in the lecture of blood transfusion, and the limitations of colloid, no oxygen carrying capacity by colloid, just increase in the volume, but not increase in the oxygen carrying capacity, that only increase by giving the blood itself contain hemoglobin. Limit on amount to be used per 24 hours because it may lead to mentioned complications and biochemically different from that of plasma. Limitations of replacement fluid, 0.9% saline or ringal lactate, no oxygen carrying capacity, small biochemical differences in plasma, does not stay in the circulation very long, need larger quantities to fluid resuscitation, triple the amount of lost fluid. Regarding the 5% glucose, no oxygen carrying capacity, essentially metabolized to water and carbon dioxide, very poor volume expansion because it moved to the intracellular compartment. Thank you very much. If you have any question or comment, I'm ready to hear from your side.
استاذ عفوا تسمعني؟
تفضل.
الديفيسيتس قلنا الاستيميشن typically replaced قلنا over first 3 hours. شنو المقصود بالفيرست 3 hours of what؟ يعني انه هو البيشنت بالورد لو بالاوبريشن روم؟
لا بالاوبريشن روم. يعني
بالاوبريشن روم.
يعني نفرض يعني انت عندك
نعم.
ديفيسيت، خلينا نفرض 1 لتر.
نعم.
اول ساعه تعطي 500 مل، ثاني ساعه 250 مل، وثالث ساعه 250 مل. هذا الديفيسيت، يعني هذا
نعم.
بس تحكي عن الديفيسيت. بس انت
نعم.
عاده من تسوي ريبليسمنت مو بس الديفيسيت، وياكو مينتننس، وياكو بلاد لوس، بس regarding the deficit to be replaced in such way.
اوكي شكرا.
يعني اذا العمليه مثلا طولت اقل من 3 ساعات، ساعتين، عندك جزء يتكمل بوست اوبراتيفلي.
جيد شكرا.
عفوا. Any other questions or comments؟
تعرف استاذ؟
تفضل.
استاذ بس عندنا الاكسسيف نورمال سلاين انفيوجن راح يسوي لنا هايبر كلوريميك، قلنا ميتابوليك اسيدوسيس. زين
رايت.
العفو استاذ، هنا مو انه المفروض الاسيدوسيس يسوي شيفتنج للبوتاسيوم من الانترا سيلولار للاكسترا سيلولار، المفروض يصير وياه هايبر كليميا.
نعم.
فهنا شلون دا يصير عندنا هايبر كلوريميك وهايبو كليميا؟ يعني الديليوشنال لو؟
لا، هذا هايبر كلوريميك لانه اكو كلورايد.
نعم استاذ، هذا بسبب الاكسسيف نورمال سلاين.
اي
هنا
لا.
راح يصير عندنا اسيدوسيس.
نعم، الاسيدوسيس شو تسوي لنا؟
المفروض شيفتنج للبوتاسيوم من الانترا سيلولار للاكسترا سيلولار، فالمفروض يصير وياه هايبر كليميا.
اي احنا هو يصير، بس احنا ما كنا نحكي على هذا الموضوع. يعني هو يصير
اكو العفو استاذ ذكرت انه بالمرتين انه بالهايبر كلوريميك يصير وياه هايبوكاليميا.
اي هذا غير موضوع. هذا هنا اللي دا يصير، انت ايش قد النورمال بوتاسيوم كونسنتريشن مالتنا؟ نورمالي خلينا نقول نورمال
3.5 الى 5.5.
زين. اكو فد واحد، اكو فد مريض عندك، يعني انا دا احكي هسه يعني ماثماتيكلي كانما دا احكي رياضيات، هو مو كلينيكال.
نعم.
خلينا نفرض واحد يعني نص دمه فقده، نص دم،
تمام.
وعوضنا هذا نص الدم بنورمال سلاين، رجع طبيعي. خوش حكي. هسه هو رجع طبيعي، فماثماتيكلي ايش قد راح يصير البوتاسيوم ليفل apart from shifting؟ ما بدنا نحكي عن
يعني المفروض يقل، يعني اول شيء صار انه احنا انطينا السوليوشن.
ايش قد يقل؟ للنص.
تمام.
مو صحيح؟ للنص.
تمام.
فهذا الشيفتنج هسه لو ايش قد ما يصير شيفتنج راح يوصل يعني يسوي كومبنسيشن؟
لا لا شيء.
هو ايده. اكو any other questions؟
عفوا استاذ، بس الهيموراجيك شوك
نعم
هن كلاسات، يعني اذا كلاس 1 قلنا less than 75 مال، اذا احنا راح ننطي هناك فريستايلويد يصير يعني استاذ مثلا ننطي كولويد؟
لا
عادي.
لا، لانه الكولويد
نعم
قلنا associated with possible complications.
نعم.
We not use a colloid unless indicated when the crystalloid not enough to resuscitate a patient with blood loss. فمن ما تكفي يلا ننطي كولويد.
يلا تمام ان شاء الله. شكرا استاذ.
عفوا.
استاذ اذا تسمح لي سؤال الله يحفظك.
تفضل.
استاذ بالنسبه للدايبيتيك بيشنت يعني ليش يصير يعني بوليوريا؟ is it because يعني هايبر اوزمولاريتي بالتالي؟
نعم هايبر اوزمولاريتي.
تمام. شكرا
استاذ. سبب الجلوكوز.
شكرا استاذ.
العفو استاذ، اذا امكن سؤال.
تفضل.
دكتور بالنسبه للرنجر اكو عن جمله مكتوب يعني بالامكان نعطي اكثر من 40 يمكن لتر
صح
يعني خلال 24 ساعه والالكترولايت ريمين نورمال.
اي صح.
دكتور ما اعرف يعني
اولا هذا المقصود من عندها، يعني هنا المريض يكون طبعا ما عنده مثلا رينال فيلير، هارت فيلير، ما عنده، يعني خلينا نقول يانج ادلت خلينا نقول، وهذا المريض دا يصير عنده دا نحتاج نعطيه خلينا نفرض 40 لتر على سبيل المثال، اللي هي يعني فد imagination just for imagination. فهنا اللي دا يصير انه احنا دا نعوضه بالصوديوم، دا نعوضه بالكلورايد، بوتاسيوم، دا نعوضه بالبايكارب، الاوزمولاريتي نير ذا اوزمولاريتي، الاسيديتي نير ذا اسيديتي، عند هذا البيشنت good renal output and normal other vital organs، فما راح يصير عندنا بروبلم. لكن نفس هذا المريض لو كنا نعطيه احنا نفسه 40 لتر اوف جلوكوز، ايش راح يصير عنده؟ نفس هذا المريض اذا نعطيه 40 لتر of glucose ايش راح يصير عنده؟ راح يصير عنده اولا hyperglycemia،
هايبرغلايسيميا،
ثانيا decrease in the osmolarity، ثالثا راح يصير عنده shifting of fluid from extracellular compartment للintracellular،
انتراسيلولر.
راح يصير hazardous problem. مو صحيح؟
صحيح دكتور.
نفس هذا المريض اذا نعطيه نورمال سلاين راح ندخل بموضوع الاسيديتي والاسيدوسيس، وراح ندخل
والهايبر كلوريميا،
وراح ندخل بموضوع الهايبوكاليميا لانه الرنجر ما بي بوتاسيوم
ما بيبوتاسيوم
وما بي يعني اذر الكترولايت. فهذا نذكر من باب الايماجينيشن على الامبورتنس اوف giving ringer lactate which is nearly similar to physiologic constituent of the fluid.
شكرا دكتور، تسلم.
العفو استاذ، بعد سؤال
تفضل.
ولو يعني تعبناك.
تفضل.
عفوا، بس هو بنفس هذا السلايد مثلا اذا البيشنت يعني خلينا نقول شويه انيميا،
نعم،
يعني ايش قد لوس يعني نبدا وياه ريد سيل.
هذا
يعني
هسه دخلتنا موضوع ثاني اللي احنا اخذناه في محاضره البلاد ترانسفيوجن. محاضره البلاد ترانسفيوجن قلنا about 10 no need 10 hemoglobin 10 gram per deciliter no need to give blood. قلنا below 7 we have to give، يعني حتى without loss ما عندنا ولا من loss، والهيموغلوبين مالتنا less than 7 we have to give the blood. Between 7 and 10 we have to consider other risk factors. مو صحيح؟ هذا الموضوع يعني كله حكيناه بتفاصيله في محاضرة البلاد ترانسفيوجن.
نعم، مشكور استاذ.
نعم.
عفوا استاذ، عندنا الهالف نورمال سلاين 0.2 نورمال سلاين، قلنا يوسفول بيشنت للسولت لود ومور فري ووتر. عفوا اللي هم قلنا هارت فيلر او بيدياتريك ايج جروب. عفوا استاذ، السولت لود مو الهايبرتنسيف يعتبر؟ يعني هو نفسه عادي نستخدمه بالهايبرتنشن؟
ما فهمت شنو سؤالك. الو